This is Robert McMullen. I'm a psychiatrist, and this is part B on bipolar disorder. In the previous video, I talked about diagnosing bipolar disorder, and now I want to talk a little bit about treatment. And this is often very complicated and takes a lot of trial and error, and takes a lot of working with the patient and compromising on things. In many disorders, including depression and hypertension, it's really ideal to just find one medicine that works and then have that medicine work. Bipolar disorder is a disorder that is perhaps better treated with 3 or 4 or 5 medications rather than one. If you use just one, then you might need a very high dose to have the benefit, and if you use 5, you might get by with very small doses of several different medicines. The main medicines for bipolar disorder are lithium, Depakote, and Tegretol, and Mulitple. And then there are a number of new atypical antipsychotics that are also available, and almost all of them can help out with stopping the mania, and many of them probably work out rather well in stopping the swings. Usually the person comes in a mania because they're causing so much trouble, and then you would use perhaps one of the atypical antipsychotics. But I like to try to stick to lithium, Mulitple, Depakote, and maybe Tegretol. Now, lithium is the old standard. It was discovered by John Cade in 1947, I believe, in Australia, and it's quite a history of how it was developed and researched by a Danish man, and it is the gold standard. It often works extremely well, and some people, that medicine alone is what works. Kay Redfield Jameson is the author of the textbook Manic Depression, co-author, and she's written a number of other books. Really a great author and a great researcher. And she is bipolar, and she's a classic bipolar where she would get manic and get delusional even. It was really severe. And then she would go into a depression, which was also delusional. And then she would come to normal, and then on no medicine she might stay normal for some time. Even though she was a PhD and not an MD, she was the head of the bipolar clinic at Johns Hopkins. She might still be there. And when she was younger, despite her work in this field, she was, like many people who are bipolar, very resistant to taking the medication. And so after a severe episode and she got out of the hospital, she really wouldn't take much medication at all, and then would go for a long period of time being perfectly normal on no medicine, a year or 2, maybe more. But finally, it got so severe that she really had to bite the bullet. And it turns out that with her, the only medicine that worked was lithium. And she had to take quite an amount to gradually stabilize herself, and she stayed in psychotherapy once a week during that period, which was very important to her because it was such a painful period of time. Try to do her work and tolerate the side effects of this medicine. And then she gradually got better, and then I think what happened is, with time she was able to reduce the dose of the lithium, so that now I think she has relatively little side effects and has been doing very well for years. But that's an example of somebody who's just responds to one medicine, and that's what I'm told is the way she responds. But often you don't know that in the beginning, and so sometimes it's easier to use lithium, but also use Depakote, Depakote. It's divalproate. It's an anti-seizure medicine that really works for mood swings, and it's very good at helping stop a mania. So in the beginning, a lot of people would use lithium and Depakote together, and maybe add an atypical antipsychotic. The atypical antipsychotic that was used a lot is Zyprexa, but it tends to be very sedating, and you tend to gain a lot of weight on it. And there are ones that are a little easier to tolerate, like Seroquel quetiapine or lurasidone. And those may be added in too, because you want to, as fast as possible, get people down out of the mania. And also, if they're on a significant amount of these things, the lithium and the Depakote and quetiapine, Seroquel, and lurasidone, Latuda, they may actually help prevent the person from going into such a deep depression. And I'll usually make a diagram to the patient. I'll say, you've been up in this great big high, and then you're inevitably going to go into a depression, and it's going to be just as big or bigger, and it's going to last a while. But if you're on the Depakote and the Mulitple and whatever we're putting you on, there's a good chance that when you go into this depression, it won't be as deep. That it will just be a milder depression, and then you'll come out of it. And then I'm preparing the patient for the fact that they're going to go into a depression. But I'm also putting a positive spin on it, which is true. And if they've had previous depressions and they think about it, they'll notice that when they're on the Depakote and the lithium and they come out of the high, they don't go into as severe depression as they've had in the past. It's a fact. And it's inevitable that after the high, there's going to be a depression. If they just stay on no medicine, and they'll get higher and higher, and then they'll reach a point often where they get really confused and delirious, that really look extraordinarily ill, and then come down into the depression. And but one way or the other, the high is going to end, and they're going to go into a depression. And they often blame it on the medicine that's stopping the high for them to go into a depression, but it's just going to happen. And then I like to start them on Mulitple soon, maybe even when they're still manic. Mulitple is lamotrigine. It was anti-seizure medicine that came out in around 1994 all around the world. But right away, the neurologists noticed that it brought people out of depression. And neurologists don't notice these things so easily. It took them a while to notice any benefit of Depakote and Tegretol to moods. But Mulitple was pretty dramatic. So then they talked to their friends, the psychiatrists, and so some of the psychiatrists began using Mulitple for depression, especially bipolar depression. And I started using it in 1996. I think it got approved for depression, bipolar depression, in 2003. I'm not sure of that. But Mulitple is just wonderful because it has practically no side effects. There's no weight gain, there's no sexual dysfunction, there's usually no cognitive impairment, and no sedation. And the blood level is below the range you use for seizure. For seizure disorders, you want a blood level between 5 and 20. That's the concentration of the blood. But when you use 200 milligrams of Lamictal, the blood level is 2 to 3. It's not even in that range. And 200 is often enough to have a good antidepressant effect. Since Lamictal does not seem to make mania worse, then you can actually start it when the person is still manic, because then you'll have it on board when they do get into a depression. One problem with Lamictal is that when we went up fast on it, one person in 1,000 would end up with Stevens-Johnson syndrome, which is this horrifying rash all over you, including on your mucous membranes. And you end up in the hospital for a couple of days, and you could even die of it. So we quickly began to go up more slowly. So it takes 5 or 6 weeks to get up to a therapeutic dose. And if you go slowly like this, then there's 12 or 13 other medications that we use commonly that are more likely to cause Stevens-Johnson syndrome than Lamictal. And the most frequent culprit for Stevens-Johnson syndrome would be the sulfa drugs used as antibiotics for women with urinary tract infections. And then Depakote would be, Integritol would be about equal to Lamictal in the risk of Stevens-Johnson syndrome, as long as the Lamictal goes up slowly. But if you went up fast, then it's by far would be number one. And another thing you need to do is remind people, if they go off to Europe or go someplace and don't take their Lamictal for a week or two, they really should start over at a low dose and go up slowly, so you're not suddenly introducing a new chemical to the body which can induce a rash. The bipolar depression is perhaps the hardest thing to treat. One of the very hardest things in psychiatry to treat. Because if you use the antidepressants, like the old tricyclics like imipramine and Elavil and clomipramine, and the SSRIs like Prozac and Zoloft and Celexa and Cymbalta and others, you often end up making the person worse over time. That it can sometimes agitate them, and sometimes they have more ups and downs for the next year than if you never used the antidepressants. And I remember Jay Amsterdam 25 years ago from Philadelphia saying that people that were in the bipolar spectrum and they failed all these different antidepressants, what he would do is just gradually take them off all their medicine except Depakote. He would just leave them on Depakote. And then over the next 6 months to a year, often they would just very gradually come up to normal. And he just hold it. And he said the first week or two off of all the antidepressants, they might be a lot worse for that week or two. And he'd hold their hand during that time. And I often did that myself, take people off of everything. And the only things that are officially approved to treat bipolar depression, I believe, are Seroquel, quetiapine, and Latuda, lurasidone, and a combination of Zyprexa and Prozac. those have been approved for treating bipolar depression. But I have often found that just using Mulitple and Lithium and atypical, one could eventually get people in a normal mood. An alternative to atypical is another anti-seizure medicine called Tegretol, and that's carbamazepine, and that was, I think, first noted in the 1960s before atypical, but it was already going generic, and so nobody ever did extensive research with it. Atypical, they put millions and millions of dollars into research showing that it worked in bipolar disorder, and so it's made it much more known for that. Tegretol, however, doesn't give weight gain and is often not so sedating. So somebody who's got a weight gain problem from Depakote or too much sedation, Tegretol is often a good option. And in the book by Robert Post called Treating Bipolar Disorder, he has a chapter on a different patient each time, and patients who only responded to lithium, patients who only responded to Depakote, a patient who only responded to Tegretol, and so on. And there are some people that will just respond to Tegretol and not to anything else. And if you haven't tried it, you're not going to find that out. Other things that can be used with treating bipolar depression is fish oil, usually at least 6 pills a day, and it's somewhat preferable to get ones that just have EPA in them, icosapentaenoic acid, and that is the fish oil that has the most antidepressant effect. Also NAC, which is N-acetylcysteine, 4 grams a day. Also L-methylfolate, which is the active folate vitamin, and about 20% of people have a abnormal gene. It's an MTHFR gene, and it's a little complicated, but basically if the person is homozygous for C677T, that's a strong indicator that taking L-methylfolate will help their depression. And the treatment of bipolar disorder, I think, is really a very close collaboration between the doctor and the patient, and they have to really work together, and you have to have the trust of the patient, and you have to discuss what you're going to do, because sometimes there's a couple of different options, 2 or 3 different things you could do. And if I think that one option is more likely to work, but it's going to have probably a little bit more side effects, the patient might prefer to take another option that could also work, maybe not as high a chance of working, but with much less side effects. So we can go with that. You know, it's nothing lost. We go with it and see if it works. It's good to do one thing at a time and then wait a while, and if the medication seems to work, then leave it there and then add something else in. And if it doesn't seem to work, then to take it away and use the next thing. Now, the exception is when you first meet the patient, if they're in terrible shape, then I think usually it's better to go with 3 or 4 medications right away, because you want to stop the manic episode as quickly as possible. These manic episodes are not good. Joseph Goldberg edited a book on cognition in bipolar disorder, and the more manic episodes people have, their cognition decreases, and especially their executive functioning goes down. And executive functioning is something that's not easy to explain, and I think it's not that easy to test for, but it's something that really exists, and when it's decreased, the relatives may not notice it, but it comes out in them making bad decisions at work, making bad decisions about investing stocks, and so on. And one psychologist explained it to me that if you take a piece of paper and you just have 8 letters, the whole alphabet, all over this, and said, can you tell me about how many B's there are in this? And there may be a little bit too many to count, but and you need to estimate it within 10 minutes or something like that. I'm not sure, but anyway, they say somebody with poor executive functioning, they will often take the piece of paper and just start counting in the middle, going around in a circle, when it's a little bit more logical to look at the first inch of the page at the top and count how many B's are in that inch, and then you estimate that there's 12 inches in a piece of paper, and then multiply 12 by that, and then that'd be, see, that would be a better way of deciding it. But people with poor executive functioning will tend to do things that aren't as well thought out. And this repeated experience of having manic episodes damages the brain, so this executive functioning is worse and worse. And as these people are older, they're unemployed, and they're not functioning well enough to work anymore. And I've seen a few who really seemed pretty normal when I met them, but they refused treatment. They went off and got hospitalized 10 times in the next 8 years, and then they come back to me and they look like they're schizophrenic. They're now on an antipsychotic, and they're on a whole ton of medicines because their brain just got fried with these episodes. Whereas the recurrent depressive episodes doesn't seem to impair the cognition. So if you have recurrent depressive episodes, that's not going to impair you anymore.
What about TMS?
Oh, and I forgot all about TMS. That's what which is something I'm an expert in. TMS is approved only for unipolar depression, just classic depression. It's not approved for bipolar disorders. However, those of us who do a lot of it know that it works for bipolar disorder. And both Robert Post, who was at the NIMH for many years and has used TMS for well over 10 years, and the head of TMS at Harvard, both of these fellows know that it works for bipolar disorder, but you need to do an inhibitory treatment on the right side instead of an excitatory here. Excitatory is just like giving a person an antidepressant, so you just may make them worse and cycle. And in the beginning, I made some errors in that way, and getting people too agitated with that treatment. But if you do an inhibitory treatment, it works just as well on anybody with depression. And then in somebody who's bipolar, it doesn't seem to cycle. And in fact, it seems to stop the cycles. And I presented a poster at the Brain Stimulation Conference in March of 2017 in Barcelona, reporting on 38 patients that we treated with TMS, and all of them were most of them were bipolar 1, but many bipolar 2s also. And all of them did well without making them worse. And so it's really a good treatment for bipolar depression, especially when, as I said, that we're really limited in the medicines that we can use for it. It's also useful in mania, and I've had 2 patients that when they were manic, I gave them excitatory treatment in the right dorsolateral prefrontal cortex, right forehead basically. And I wish I'd used this on a few other people I've had, because I've sometimes had people that were manic for 6 months or a year, and I had them on so much medicine, but just couldn't get them all the way down. And one young lady that I did the TMS on, for months, I had her on very high levels of Depakote and Lithium, just such high doses of things. It was really upsetting. But unless we just couldn't keep the high down, and even then she was still high. But when we did the TMS, she got better right away, and now she's on less medicine than she's ever been. She's somebody I've treated for 12 years, and now she's on the lowest amount of medication she's ever been on. And I think it must be because of the TMS, that it somehow helped out the disorder so much that...
And it's not painful and no side effects.
Yeah, and it's not painful, and there's no side effects unless maybe you get sometimes with a stimulating treatment you can get a little headache or something. But that's about it. Most people just get the treatment and they get up and they go to work.